صباح الخير. أنا اسمي هاني نعيم. أنا استشاري السكر في دي ان سي، وأنا بكلمكم النهاردة من روما. جاي أحضر مؤتمر المريض. ده مؤتمر الجمعية الأوروبية لالتهاب الأعصاب السكري، وقابلت هنا صديقة عزيزة أعرفها من زمان جدا. هي أستاذ السكر، لسه هخليها تقدم نفسها. وده كده آخر المستجدات من مؤتمر الجمعية الأوروبية للسكر في روما. Good morning, Mitra.
Good morning.
Yes. Would you please tell me first, would you like to introduce yourself to the people of Egypt?
Yes. صباح الخير. My name is Professor Mيترا Tafakoli. I'm an associate professor in medical school at the University of Exeter in England. And my research is mainly focused at the field of diabetic neuropathy and peripheral neuropathy.
Okay. So, your main field of research is peripheral neuropathy rather than cardiac autonomic, rather than anything else.
I'm focused in a range of conditions that cause a small fiber damage, including diabetes, condition with a rare disease, but also there is a long list of conditions that neurologists usually call them when they cannot diagnose the exact reason for that as an idiopathic small fiber neuropathy. In the last 15 years,
Idiopathic means something of unknown cause.
Yes.
Okay.
Therefore, that can be a condition including absolutely because of neuropathy, something like vitamin B12 deficiency, HIV, or condition secondary, like a neuropathy due to induced chemotherapy, or a condition with rare diseases like Alström syndrome, a rare type of diabetes, Fabry disease, and the list goes on and on. But one of the main causes of this type of small fiber damage is diabetes, which is the main focus of my research in the last 15 years.
Wonderful. Okay, so would you like to tell us more about how you measure neuropathy?
In the research base or in the clinical?
Both.
Both. Therefore, my background is a little bit unusual because I train in ophthalmology and optometry. Therefore, my clinical practice is in the field of refractive surgery, cataract, and intraocular lenses. However, most of my time, 80%, I'm focusing the research. And we brought the combination of some new innovative markers, including ocular, ophthalmic biomarkers, to the field. And our research is based on that. In the clinical setting, as part of our research in patients with diabetes.
So your actual title is Professor of Ophthalmology rather than Diabetes?
My title is Professor of Medicine.
Medicine?
Yes.
Not ophthalmology and not diabetes?
Yeah, because it's a mix of both of them. And also I do lots of research in the rare diseases. Therefore, that was difficult to bring the title together. Therefore, my title at the university is Professor of Medicine.
Are you a practicing ophthalmologist or a practicing diabetologist?
In ophthalmology.
Ophthalmologist.
Yes.
You still are ophthalmologist?
Just 10% of my time.
And 90%
is research and diabetes.
Research and diabetes. You see, this would be very difficult for the people back home to understand.
Yes. Therefore, we want to focus only in diabetes and neuropathy. Forget the part of clinical practice.
Okay. So let's take it a step further.
Yes.
You were talking about your role as an ophthalmologist.
I'm going to talk about my role as a professor of research in diabetes and neuropathy.
How does an ophthalmologist fit?
That part came from my background when we started to do these ocular biomarkers using corneal confocal microscopy.
Okay, what's that?
And the corneal confocal microscopy is a relatively new technology that introduced in the early 2000s, and that enables ophthalmologists and vision scientists to assess the corneal layers, the first part of the front of the eye, in a much more details in vivo.
Okay, so
therefore,
cornea
originally
is the window of the eye, the outer part.
Yes, and that's a transparent structure of the eye.
Okay.
2/3 of power of the eye, the refractive power of the eye, comes from the cornea.
Okay. Refractive means what makes the focus of the light
Yes.
so we can see.
Absolutely.
Okay.
And the cornea, from the anatomic point of view, has 5 main layers.
Mhm.
Therefore, those layers can be changed due to various conditions, like a dry eye, having any kind of ocular surgery,
Mhm.
especially refractive surgery, some
Okay.
kind of systemic condition like diabetes,
Mhm.
and lots of kind of congenital disorder.
Okay. So basically, what you're saying is you look into someone's eye and you say he has diabetes, and this diabetes has caused neuropathy.
Yes.
Okay.
Therefore, this technology of corneal confocal microscopy allows us to look at the nerves in the eye, in the cornea,
Mhm.
and the cornea has the highest level of the nerves in the body.
Mhm.
That's the reason you cannot touch your eye, but you
Mhm.
can touch your skin.
Okay.
And the type of the nerves in the cornea are exactly the same type of nerves. They call them C fibers, that
Yes.
they are responsible for pain and sensation.
Okay.
Therefore, traditionally, to look at the nerve damage because of the pain that happens in diabetes,
Mhm.
we, apart from the non-invasive test, the only test was to do a biopsy
Okay.
from the skin area and then look at the nerves in a laboratory to see if there is a damage or not.
So basically, what you're saying is, what you do is you look into someone's eye
Yes.
instead of taking
Doing a
a
biopsy.
piece of the
Yes.
skin and looking at it under the microscope in
Yes.
the lab.
Yes, therefore, this confocal microscopy allows us to look at the nerves non-invasively and then be able to repeat it over and over the time and see if there is any sign of nerve damage that can cause by diabetes.
Okay. So if corneal confocal microscopy is
Yes.
so good at diagnosing things,
Yes.
and you don't need to take a piece of skin out of someone,
Yes.
why don't we all have it in our clinics?
There is several reasons for that. And this is a research ongoing for the last 20 years
Yes.
in many labs across the world. The issue for diabetes in particular is a very complex condition.
Yes.
And the nerve damage in diabetes is not a specific type of a small fiber damage.
Mhm.
It's a combination of large and a small fiber damage.
Okay.
Therefore, at the clinic, as you do it for large fiber, usually we do a nerve conduction
Yes.
or a combination of like a physical examination,
Okay.
or the patient can have autonomic neuropathy. Therefore, you can do some another test.
Okay. Can we elaborate? So what you are saying is with diabetes,
Yes.
we have the main three nerve systems which are damaged.
Yes.
The large nerves is something
Yes.
which I can see with my eyes and hold with my hand. It
Yes.
is something of significant size.
Yes.
Okay. And the small nerves, which I can only see using a microscope,
Or
of
doing a
some-
biopsy.
which is seen also
Yes.
under with a microscope.
Yes.
Okay. And the autonomic nerves, which are the nerves controlling things which we cannot control, like our heart beating,
Yes.
like how how fast we breathe when we're not
Yeah.
focusing to do it, how fast our bowel is working. Okay. These nerves,
Yes.
all three types are damaged by diabetes.
Yes.
From the eyes, you can see the equivalent of the small nerves,
Yes.
okay, which you can only see from taking a skin biopsy and looking at it under the microscope.
Yes.
Is it as good as a skin biopsy?
Yes. This is a very good question.
Yes.
Lots of research has been done, and as from the research point of view, we say a test is good when there is a good repeatability,
Yes.
acceptance from the patients,
Mhm.
and more important from scientist and clinician point of view, the sensitivity of the test.
Sensitivity meaning if I see the result,
Yes.
okay, if I find it, it's actually there.
Yes.
Okay.
And the correlation with the gold standard test.
Okay.
Which is
Correlation means how well they go together.
Yes. Therefore, at the moment, the gold standard is a skin biopsy.
Mhm.
And therefore, we and others have done lots of research show
Yes.
that this assessing by corneal nerves and detecting the neuropathy has very high repeatability,
Mhm.
good sensitivity, good specificity for this condition,
Okay.
and highly correlated with what we see with doing a skin biopsy.
Okay. Now, Why don't we have it everywhere?
The problem is that still is quite novel technology. It's expensive. It needs a trained clinician to be able to do a test, and also trained clinician to analyze the outcome.
Okay, let's say it another way in layman terms. It needs very expensive, big equipment, which needs ultra-trained professionals to do it.
Yes.
Not one, we're talking about a team just to
Yes.
do the test. And it takes, how much time does it take per patient?
The test is very fast. It takes less than 5 minutes for a trained clinician to do the
Okay.
test. The analyzing, there is a various option. There is from basic manual analyzing the images to now automated and visualize medicine.
Now it is automated.
Yes.
If I remember, it took something like 3 or 4 hours using the manual analysis.
It takes manually, it takes around maximum 15-20 minutes
Okay.
per patient. The automated do it in 15 seconds.
Okay. And why isn't it available everywhere? Because of its cost?
It's not that much expensive compared to the other tests that we do in medicine. Therefore, the cost of this device.
What do you mean by other tests?
For example, if you want to do a nerve conduction, for example, the EMG device or more other tests like MRI, and considering the cost of diabetic neuropathy.
Comparing MRI for a test, we're talking about a complementary test.
Yes.
Okay, like
Absolutely.
we're not using it to diagnose a brain tumor.
The other major problem is that even when we diagnose in the field of diabetic neuropathy, there is really no treatment.
Yes.
And that's really puts lots of strain in developing new diagnostic tests.
Okay. You mean like no final treatment? But
Yes.
there are many things which...
They are just mainly as a
pain management.
Yes.
And improving the patient's condition generally improves to
But
some
the pain
extent.
management doesn't improve the pathophysiology of the condition. And
pain management?
Yes.
Pain management doesn't
improve the situation. Therefore, it doesn't regenerate the nerves. It doesn't improve diabetic neuropathy.
Okay. But we have seen with our researchers that if I give proper diabetes control, good blood pressure control, good lipid control, I make this patient stop anything which is harmful from the nerves, like smoking. I make him exercise. This tends to improve the small fiber nerve function. Yes, indeed. Yeah, there are lots of research show that the nerves can regenerate if we detect early and prevent further progression. We show that if we put in patients with type 2 diabetes in a lifestyle management, change their diet, exercise, the level of activity, and bring their blood sugar down, we show that over 3 years' time, the nerves actually regenerate. And some of those, around 20% of those patients, back to normal without diabetes. Yes. That apart from the neuropathy, prevent any further damage to their eyes and for their vision. Okay, so if I have someone and I do him, for example, bariatric surgery. But that's extreme management. It should bring the HbA1c to a lowest possible level. If we take the best case scenario, I get someone who is diabetic and I take this person and I make a bypass surgery. Yes. Okay, gastric bypass surgery. And then next month his hemoglobin A1c drops from 12 to 4. Yes. Okay, which is something we've seen multiple times in our practice. Okay, what happens to his nerves 6 months later, say? It doesn't happen over the night. We've shown in the patients even undergoing pancreas transplant, which means that anatomically they don't have type 1 diabetes anymore. The standard tests like nerve conduction and skin biopsy show it takes 4 years that the nerve start to regenerate. With using the corneal nerves, because they are much more sensitive to the changes, it has been shown it takes around 9 to 12 months to see the improvement in the neuropathy and in the symptoms of the patients. And how long does it take for the best results to come? It doesn't go back absolutely to a normal level, but that can be maintained. The research has been done. There's not too many long
duration studies, but it shows that up to 4 years, the patient still benefit from this.
So basically, if I have someone and we do bariatric surgery,
Yes.
to decrease weight losing surgery to decrease his blood sugar to make him become non-diabetic, we can have improvement in his nerve condition, which continues to improve for the next 4 years.
Yes.
Okay, he won't come back to normal, but he will be as close to normal as we can dream.
And we prevent further damage, which is extremely important.
Wonderful.
The other thing for bariatric surgery that you mentioned in type 2, if the obesity is the causes of that part of diabetes, one of the important effects of bariatric surgery is that the obesity is related to increasing the inflammatory markers.
Yes.
And with using the cornea, we can see some of
Like
those
CRP.
inflammatory markers.
Yes.
And there are lots of research now shown that the role of those inflammatory markers to make the damage even actually is higher than the actual nerve damage. Therefore, bringing the weight down and controlling all of the risk factors can improve the neuropathy.
So now you're talking more about obesity-related neuropathy rather than diabetes-related.
Yes. But it's like a pieces of the chain that work together.
Okay.
Therefore, the inflammatory cannot be separated from diabetes on its own, unless if you look at the cohort of patients with no obesity and the standard BMI compared to a group of controls.
Okay. So by this, let's summarize what we talked about.
Yes.
First, we went through that diabetes causes nerve damage, diabetic neuropathy, which can be to large fibers and to autonomic fibers and to small fibers, which can only be seen using a microscope.
Yes.
These fibers, which we call C fibers, are present in the cornea of the eye. That's the glass part outside.
Yes.
Okay, glass-like part.
Yes.
And this the cornea nerves change very rapidly according to the general condition of the person, reflecting how he is doing. And then we talked about different modalities, including bariatric surgery. And we said at the end that bariatric surgery really does improve these nerves. Thank you so much for being with me today. And let's hope we can have another episode.
Yes.
Thanks.
That's a pleasure. Thank you very much for inviting me. Very nice to talk to you.
Thank you.